Good morning or good afternoon to everyone. Welcome to the Show Me a Better Quality of Life. Innovations in prostate cancer screening and care. This is being presented by Siteman Cancer Center, Washington University School of Medicine, BJC Healthcare, and the Empowerment Network. As you come on to the presentation, you will see a pre-test in front of you. Please take it very quickly, 6 relatively simple questions. It's a pre-test, and you will be post-tested toward the end when we will have the tally of both of them. We're going to proceed with bios and presentations from our guest speakers this morning. I'm going to introduce them, and you will see on your screen the presentation of what they will be discussing. And we will have questions and answers. And if you have any questions or chat, please put it in the screen, and we will follow up as we move forward. So we're going to begin with Dr. Gerald Andreoli, a urologist, the Robert Killian Royce, MD, Distinguished Professor and Chief of the Division of Urologic Surgery at Washington University School of Medicine. We have Dr. Melissa Reimers, a medical oncologist, Assistant Professor of Medicine, Division of Oncology at Washington University School of Medicine. We also have Dr. Arnold Bullock, urologist. He's the Alan A. and Edith L. Wolf Professor of Urology, Washington University School of Medicine. We have with us also Dr. Lannis Hall, a radiation oncologist, Associate Professor of Clinical Radiology Oncology, Washington University School of Medicine. We also have with us DeAndrea Blaylock Johnson, a sexual and relationship therapist and school social worker. She is the president CEO of Sankofa Sex Therapy, LLC. And finally, we have Dewey Helms, who is a prostate cancer survivor. He is the Speakers Bureau president of the Empowerment Network. I welcome all of you. We're looking for a very good 90 minutes of great information and great Q&A from our audience for better knowledge about prostate cancer. So we're going to begin with Dr. Andreoli and his presentation.
Robin, thank you very, very much for the introduction and the opportunity to speak today. And I'd certainly like to congratulate Kelly, Nora, Keisha, and all the others who have really organized what looks to be a terrific program. And I'm really looking forward to a lot of back and forth with the panelists and with some of the other participants. So if I could have the next slide, please. You know, we have made a significant improvement in how we care for men with prostate cancer by screening for it, which means testing for it before any symptoms develop. And we've really been doing that for the last 25 to 30 years. In fact, the first study of any size testing PSA screening for prostate cancer started right here in St. Louis. But we've learned a lot along the way. And what we now know, I've tried to put in 3 sort of simple points on this slide. We should not screen all men the same way. Why is that? Because some men are at very low risk for prostate cancer because of their lifestyle or their genetics. On the other hand, other men are at much higher than average risk of prostate cancer because of genetics or diet or lifestyle features. And it's kind of silly to look for prostate cancer with the same intensity in both groups of men. So who are the men who are at high risk for prostate cancer? African American men, men with a strong family history of prostate cancer, and by that I mean men who have more than one first-degree relative who has had prostate cancer. The other men who are at high risk for prostate cancer are those who happen to have a PSA test earlier than we've generally been recommending it. You know, for many years we said, well, get your first PSA when you turn 50. But now we're much more convinced that it's very important to start that testing early in life at least in the 40s and maybe even in the 30s for some men. And the thing we've discovered is that very early in life, if you have a relatively high PSA, and by that I mean a PSA only above 1, that places that individual man at a very high risk for prostate cancer. And finally, we now have a genomic risk score. This is a cheek swab. A man can swipe the inside of his cheek, send it to the lab, and he can learn whether he's inherited genes that predispose him to aggressive and early in life prostate cancer. And once we consider all of these details, we now know that men who are at above average or high risk for prostate cancer, we need to screen early and often with PSAs and other tests. On the other hand, if a man is at low risk, he probably only needs to be screened every 2 to 5 years instead of every year. And if I can go to the next slide now. So after we've done PSA and some of these other tests that have informed us that a man is at high risk for prostate cancer, we need to look for prostate cancer by biopsying the prostate. Now, in the old days, we did just random biopsies. We fired needles into the prostate, as you may see on that little diagram in the lower right, and it was a very hit or miss proposition. Nowadays, unequivocally, the best way to do a biopsy of the prostate is to do a targeted biopsy. That's where we aim at specific parts of the prostate that, on the basis of an MRI scan or a new type of ultrasound called micro ultrasound, tells us that that is the most worrisome, that is the most abnormal part of the prostate. And these kind of targeted biopsies are so much better at accurately telling us whether a man has prostate cancer. I don't think men should generally have biopsies that are done in the doctor's office without these kind of specialized imaging techniques. Finally, on the next slide, if we discover prostate cancer on the basis of one of these biopsies, I would like to remind all men not to get too upset, because many times the prostate cancers we find are not that aggressive and they don't require aggressive treatment. And there are 4 main options. One of them is called active surveillance, to just monitor that patient with PSAs, MRIs, and some of these micro ultrasounds. There are other treatments that don't cause side effects, such as ablating the cancer or doing what we call a male lumpectomy. But for the aggressive cancers, for the large cancers, there's no doubt that surgery and radiation therapy will be necessary. And one new tool that we have to tell us if it's safe to do active surveillance is to actually analyze the genetics, the abnormal genes that are present in that specific man's prostate cancer. And once we know that, we could have great confidence doing something less than radical surgery or radical radiation therapy for that man. So when we put all of these new tools together, I think we are at the time when we can provide individualized strategies to look for prostate cancer and individualized strategies to treat prostate cancer, which is so much better than what we've been doing for the last 20 or 30 years. So thanks very much again for the opportunity, and I look forward to the rest of the presentations and some discussion.
Absolutely. Thank you, Dr. Andreoli. That was very, very interesting, some cutting edge information there. We're going to move to Dr. Reimers. She will make her presentation. Start thinking about your questions, and you've got a lot more to go, but you just put them in the chat or the Q&A. Dr. Reimers.
Great. Thank you all so much. Thank you, Kelly and Keisha for the organization, and for Dr. Drake for organizing, and for Robin for the excellent moderation here. So As Robin mentioned in the beginning, I'm a medical oncologist. I specialize in genitourinary cancers, so specifically cancers of the prostate, bladder, and kidney. And so today what I wanted to talk about, dovetailing nicely on what Dr. Andriel just discussed, is whole body-wide treatments for prostate cancer. Next slide, please. So what is metastatic or stage 4 prostate cancer? Next. So stage 4, the definition is essentially that the cancer has spread from where it started, and in this case, that's the prostate, to other organs. So as Dr. Andriel very nicely outlined, of course, only men develop prostate cancer because only men have a prostate. And the treatment for localized prostate cancer, as Dr. Andriel discussed, can involve things like surgery and radiation therapy and other modalities. But where patients come to me and to my clinic is when their cancer has spread outside the prostate. And you can see here in the diagram, prostate cancer can spread to a number of different areas. Most commonly, it can spread to places like the lymph nodes and bones, and more rarely, but it can happen, to places like the lungs or the liver. Next. So this is, I think, a really important point. This is something I talk about with my patients frequently when we first meet, and this is a really key question. So Dr. Andriel mentioned all the local therapies, and of course the goal for localized prostate cancer is cure, is to get rid of the prostate cancer entirely. It's important to know that unfortunately stage 4 prostate cancer, when it's spread outside the prostate, cannot be cured. It's really on our therapies are not good enough yet that we can get rid of every single amount of cancer all across the body once it has spread. But what I really want to emphasize, and what's very important, is that the goal of treatment, which is available and which is very good, is to prolong the quantity and the quality of life for men with stage 4 prostate cancer. So it's the key take home here is that this cannot be gotten rid of entirely, but it's absolutely treatable, and we have a lot of excellent therapies, and they're increasingly more effective, but the cancer cannot be cured at that stage when it is metastatic or stage 4. Next slide. So then how do we treat metastatic or stage 4 prostate cancer when it has spread? Next. So the backbone of treatment for stage 4 prostate cancer is hormone therapy, or also called androgen deprivation therapy, or ADT. And what this does, it essentially shuts down testosterone production in men. And the reason that we need to do this is because testosterone is what fuels prostate cancer growth. And so by shutting down testosterone, we're essentially able to starve the prostate cancer. So this does not get rid of it, but it's able to put it in a remission, essentially, to essentially stop the growth, slow the growth down substantially. One of the big things that can happen, of course, though, is side effects of shutting down that testosterone. Sometimes I tell my men it's kind of like menopause for men. The symptoms can somewhat be similar, and actually their wives can sometimes help them relate to what that's going to be like. But I've highlighted here on the top some of the most important side effects of hormone therapy, which is fatigue, hot flashes, night sweats, and importantly, sexual function. And we'll talk about that more later on, I'm sure. So that becomes indefinite therapy. This is long-term treatment, that backbone with the hormone therapy. Next. And so it's important to know that depending on the extent of the stage 4 cancer, there can be different treatments that can be added on top of this long-term hormone therapy. One of those is IV chemotherapy called docetaxel. That's given by vein up to every 3 weeks. Next. And again. Or oral hormone therapy. And the important difference here is that IV chemotherapy just kills cells that divide more quickly than your normal healthy cells, which is what cancer cells do, including prostate cancer. And so there are certain situations where we can use hormone therapy along with chemotherapy, or other scenarios where the best first treatment is hormone therapy long-term, as you see with the backbone, and we add an oral hormone pill, which is taken daily. And those shut down testosterone in a slightly different way than the hormone therapy. Sometimes I like to explain it like a 1-2 punch of shutting down the testosterone with the long-term hormone shots and then adding the hormone pills. Next, please. And this, again, is the really key take-home here, is that regardless of which treatment option we add to the long-term hormone therapy, we know from large clinical trials that either of these options help our patients live longer. Next slide. And so this is a little bit of an overview. It may look a little overwhelming, and I certainly don't expect anybody to memorize this information, but it's just, and it's a broad overview of the types of side effects that you might experience. And so if you are somebody who has had stage 4 prostate cancer, or you know someone who has that, then these are the kinds of questions you'll be discussing with your medical oncologist. So you can see there on the left side of the panel, the docetaxel chemotherapy that I mentioned, which is an IV medicine that's given every 3 weeks. And in this case, it's typically given for up to 6 cycles or 6 rounds, 1 3-week cycle for 6 treatments. And so that's a total of 18 weeks of treatment. And all the while, the men are also getting hormone therapy injections simultaneously. And you can see here the side effects. As they say, you know, there's no free lunch, unfortunately. There will be side effects. There can be fatigue, the immune system can be weakened, the blood counts can be lowered, appetite can go down, there can be hair loss, diarrhea, and nail changes. But the goal of this, of course, is to decrease the PSA, which is the blood test we use to monitor prostate cancer. We also monitor with scans. And if it's effective, we see the PSA going down and we see scans improving and the amount of cancer that's there shrinking. And on the right side of the screen there, you can see the different types of oral hormone treatments. So there are currently 4 different FDA-approved pills that we can use in different stages of stage 4, in different types of stage 4 prostate cancer. That we can talk more during the Q&A because it gets a little complicated quickly. But you can see here I've listed sort of the brand names and the generic names just as a reference point. And the pills actually generally have a pretty good side effect profile. A lot of them can cause fatigue. They can sometimes cause high blood pressure, joint pain, and rashes. Some of them can cause falls and fractures, and so that's important to think about, especially in our older men that might have weaker bones. But like I said, the important point here is that in general, for treating for stage 4 prostate cancer, we give long-term hormone therapy, and then as a first treatment, we give either of these medications. And kind of as a way to wrap up the way we think about stage 4 prostate cancer is that the long-term backbone of treatment will be hormone therapy, as I mentioned. And then one of these 2 treatments will usually be the first type of therapy. And then each treatment is given for as long as it's effective, meaning it's controlling the PSA and the scans are improving and patients are continuing to feel well. And of course, too, as much as we want to discuss, clinical trials are also becoming an increasing option. And what I want to end on is a hopeful note is that we're always advancing the field and there's always new treatments coming down the line to help us improve the quality of life for our patients with stage 4 prostate cancer. And with that, I'd like to thank you all again for your attention, and we'll move on to the next presentation.
Absolutely. Thank you, Dr. Reimers. Very, very interesting, and I'm sure many of our listeners wanted to know a lot, and we'll have questions about that. Our next presenter is Dr. Arnold Bullock, and he will bring you some very good information, and I'm sure many of our audience members are familiar with him for various reasons. Dr. Bullock.
Good afternoon. I appreciate the opportunity to give a short presentation. Can I have the next slide, please? So weren't sure exactly how this was going to go, and I know that Dr. Indro has covered a lot of this, but the PSA study, a lot of the approval of the PSA was based on studies done right here in St. Louis at Washington University during Dr. Indro's and my tenure. So the PSA has clearly been in widespread use for over 25 years now, and it has been documented to show that those men who get screened reduce their risk of having advanced disease or metastatic disease, as Dr. Reimer just discussed. What many of you may not realize is that before PSA screening, if we go back to 1984, there were 2/3 of African-American men who already had advanced disease at the time they were diagnosed. There was 1/3 of whites. And now we're under, clearly under 10% who will have metastatic disease in the African-American community at the time of diagnosis. And so men with localized disease might be cured, but also men who have very localized disease, low volume, low stage disease, as Dr. Indro mentioned, might also be reasonably observed, called active surveillance. And that's not a small number. It's 25%, 25% of men will meet the criteria for low PSA, benign prostate exam, over the age of 55, low-grade disease, small volume on a biopsy on only, 1 or 2 cores involved with this lowest grade disease. Unfortunately, even though I'm supposed to talk about surgical management, I'd rather take the moment to talk about how there's been a stage migration in prostate cancer over the last several years. And what that means is that the number of men presenting with low stage disease or clinically localized disease has taken a turn for the worse. 10 years ago, we could clearly see a decline in the percentage of men who present with cancer that's already, presenting with cancer that was outside of the prostate. And so we had more men 10 years ago who were probably candidates for active surveillance or surgical or radiation treatment with the attempted cure than we have today. So why the difference? Well, the U.S. Preventive Task Force in 2012 suggested that men shouldn't get PSA screening. Unfortunately, that recommendation wasn't uniformed in how it went out. We find that the communities at highest risk, especially North County, St. Louis, had a decline in the percentage of men who were being PSA screened, whereas other communities, some might say communities of different, not of color, and more well-in communities, socioeconomic status communities, continued to screen across the board. I saw this recent article that came out in a major cancer journal called Cancer in February of last year, and it talked about how there has been this stage migration since 2012. And the conclusion is that there is a reverse migration, meaning away from indolent disease toward more aggressive disease beginning in 2012. Just to cite a couple of numbers, the number of men with clinically localized disease since 2012, between 2012 and 2015, went from 195 down to 132. That's an enormous drop. The percentage of men who have metastatic disease, that means cancer spread to some other part of the body that you could clearly define, went from 6.2, which is pretty low, up to 7.1. And that's for men between 50 and 74. For men over 75, the rate of metastatic disease has gone from 16.8 up to 22.6. And so that's why PSA screening is so important. So to get to my real task, next slide. So if by chance you have found to have prostate cancer, I know Landis Hall is going to speak next, but you really want to have surgery. And so there are many different treatment options. So even if you choose surgery, there's many types of surgeries. You could do a robotic assistant, as shown up on the left-hand corner. You could do laparoscopic. Dr. Andrew, he's not a big believer in robot. He believes that he'd rather hold the laparoscopic instruments himself in his hands and accomplish the same task making a large incision, you're working through ports. And me personally, I do more open prostatectomies. And as Dr. Andrew mentioned, one other option is to do freezing. And that's what the slide on the bottom showed. So bottom line, this is just a summary slide. Prostate cancer, #1 cancer in American men, second leading cause of cancer death. You can treat prostate cancer successfully if you participate in PSA screening. Thank you for your time.
Very, very good information. And that's what the Empowerment Network has done now for 12 years, is to provide opportunities for the community, men in the community, to get prostate cancer PSA screening. Very, 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 very important. Thank you so much, Dr. Bullock. Dr. Hall, you may proceed with your presentation.
Thank you so much, Robin and Bettina and Keisha, for the invitation. I would like to continue on what Dr. Bullock has talked about, because not only is PSA screening fallen in communities of color since 2012 in the U.S. Preventive Services Task Force, but since COVID, our most recent rates of PSA screening is less than 10%. We knew we were going to have a problem with tumors that are detected early, and survival benefits are because of early detection. We knew COVID was going to wreak havoc on screening, and that would be for breast and for colorectal cancer, for lung cancer, and for prostate cancer screening. But unfortunately, when even before COVID, only 30% of men of the age of 50 and older were being screened, and now it is less than 10%. So this increased rate of advanced and metastatic disease that Dr. Bullock talked about will worsen, and our efforts around getting people to healthcare centers and our healthcare providers to get a PSA is even more urgent during this time. I will say personally, in my practice, I have never seen the kind of disease that I am seeing now with widespread lymph node involvement and metastatic disease upon presentation. So what is in the Cancer Journal is what I see in my clinic. But I also want to say that prostate cancer is just an amazing, it's just an amazing disease because of the wide biologic variability of it. As Dr. Bullock talked about, many men present with disease that will unlikely cause them harm in their lifetime. It is just that we found it because of an excellent screening tool for PSA. But on the other hand, prostate cancer is not just the most common cancer diagnosed and the second leading cause of cancer death, but in African American men, they have 140% higher mortality rate. So there is a significant disparity in cancer survival for prostate cancer survival for African American men. So let's go to our first slide where we talk about really the importance of a multidisciplinary approach because of this wide biologic variability. And I am a radiation oncologist, so I specialize in giving radiation to cure diseases. And X-rays are delivered by a linear accelerator. That is a machine that can generate high-powered X-rays. They are not radioactive materials, so you are not radioactive. They are targeted based on, we target based on a simulation. So that's a planning session where we map out where we're going to treat. And we use a CT or an MRI to outline the prostate and the neighboring critical structures. In most practices now, we use both almost all the time. The planning process or simulation also includes a mobilization to ensure accurate positioning of the patient on the table every day, so there's no torque or twist. And we use additional procedures to target the prostate during radiation called fiducials and spacers. Can I have the next slide? Slide, please. So this is just a visual of the linear accelerator, and that orange beam is the X-ray that we can deliver as small as 1 by 0.5 centimeters, and we can customize it to the size and shape of the prostate gland, which is different for every man. And what you don't see well is that we immobilize the hips and the lower legs so that the person is laying on the table in the same position each day. And this machine can rotate 360 degrees and deliver from any angle. Next slide. And to make sure that we are able to successfully treat the prostate gland, but the other most important goal is to protect the neighboring structures, which are the rectum, which is posterior, and the bladder superior. We can place a water capsule, which is called a spacer or hydrogel. It's 80% water, the rest is polyethylene glycol, and it dissolves over 90 days, pushes the rectum back about 8 millimeters so that we can give very little to no high dose radiation to the rectum. Next slide. And the fiducial markers that you see in this particular slide helps us to localize to the prostate gland so that we can treat with just a 3 millimeter margin around it. And right below where you see those two bright spots, and it's outlined in red, that's the prostate gland, and inferior is that spacer I just showed you. So I placed that last week in a patient, and it pushes the rectum back, which is seen in blue, so that we can treat the prostate gland without treating the rectum. Next slide, please. And on a side view, you can see that bright white spacer. And so the red is the prostate gland, the spacer is pushing the rectum back. which you see posteriorly with a little rectal tube that's also bright. Next slide, please. So the advances in technology with external beam radiation therapy, one of the most significant is something called image-guided and intensity modulated radiation therapy. And it's like a dimmer switch. So if you can imagine having a dimmer on your light, but imagine that half the light could dim more than the other. So that allows us to give higher doses within the same beam to one part of the prostate and a lower dose to another part if we want it. But most importantly, we use that dimmer to make sure that we're protecting the rectum and the bladder. We can also give it in shorter treatment times with volumetric modulated arc therapy. Because we're able to target the prostate, we can give radiation in a week now, and we can use MR guided radiation called ViewRay. Next slide, please. But what I'm also most excited to tell you about, because I think it's an underutilized option, is brachytherapy. And that's where we actually place radioactive sources directly into the prostate gland. There are two ways to do it. We can either do it with radioactive sources that remain in the gland, that's called permanent seeds, and we do that with low dose radiation, or we can place a catheter in that delivers a dose of radiation temporarily and then remove it. It typically requires 2 visits, and it has different side effects acutely than external radiation, because we place all those seeds, next slide, through a needle about the size of a blood drawing needle. And we place the seeds into the prostate gland. They're threaded in a needle, and then we advance each seed where it should go and then pull the needle out. So there's no suture, and there's also no cutting at the time of this hour procedure, and you go home 2 hours later. But about 5% of men will have swelling and require a catheter for 2 days. Most men will not. And many times you should expect a little more frequency and urgency because of swelling of the prostate gland. There's a low risk of scar tissue, where I might call on my colleagues, Dr. Andriel and Dr. Bullock, to help me if scar tissue develops in the urethra, which can occur 1 to 2 out of 100 cases. Next slide. So radiation therapy is indicated for all risk groups, but I have to say it's important to talk with your surgeon, your radiation oncologist, and your family, as well as maybe seeking other opinions about how to best treat or manage low risk, intermediate risk, and high risk, because I absolutely believe that most low risk patients don't need to be treated and can be watched with active surveillance. After surgery, there can be certain reasons to give radiation therapy, and palliation in a metastatic setting can be given with external radiation or an internal liquid radiation called radium-223. And sometimes we use a combination of what I talked about in addition to hormone therapy, which is the backbone of treating men with high-risk disease, locally advanced disease, and some intermediate risk. Thank you very much. I am done.
Very interesting, Dr. Hall. Nothing like graphics and pictures to bring a point home. I want to ask you, though, before we move forward, define palliation for us.
Sure. So when we see any physician, oncologist who sees a patient in a new consultation, we need to determine the goals of therapy. And the goal can either be curative, meaning that we think there is a likelihood that we can successfully, using whatever modality, get rid of all of the cancer, and therefore our goal is cure. Or there's a situation that Dr. Reimers discussed earlier, stage 4 disease, where the cancer is in multiple places, maybe not just in the prostate, but in the bone, in the liver, in the lung. And therefore our goal is not cure, but it is in controlling the disease as long as we can, and palliating, making it better, reducing pain, reducing side effects because of the spread of cancer to other places. We don't have time to talk about a situation that might be in between a palliative setting where you have oligometastatic disease, maybe just a couple of sites of metastatic disease, where we think we're going to try to cure, but it is highly likely that maybe we won't. And that's a different state. But palliation is to improve your quality of life. It can also prolong survival, but our goal is not to cure. You know, you will be living with this disease the rest of your life.
Thank you. Very, 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 very interesting. I'd just like to remind our audience out there, if you're coming on, you're going to see a pretest, a 6-question pretest. So take that and we'll talk about it a little later. And that this is a webinar and you're only able to see those of us participating and you are muted. So if you're getting a little stressed about that, it's normal. It's a webinar. It's not our actual, especially for the Empowerment Network, it's not our actual wide open Zoom. Okay, our next presenter is Dr. DeAndrea Blaylock Johnson, and she's going to talk about sexuality and relationships and the stress of a cancer. Go right ahead.
Good afternoon, everyone. Thank you so much for inviting me. I am honored to be here amongst these other professionals. So again, thank you for having me. We'll go to the next one. You can move to the next slide. All right, so I'm going to talk a bit about life after diagnosis and treatment, specifically as it relates to quality of life and sexuality. And these are some of the common experiences that people may experience or may have that are listed here after treatment, which includes urinary incontinence, erectile dysfunction, shortened penile length, penile curvature or Peyronie's disease, dry orgasm, which is when you're able to still have orgasm but not ejaculation, and that is something that can happen when you have the removal of seminal vesicles, or which then may happen immediately after surgery, or it may happen gradually after radiation. And then you also have other things that may develop, such as depression and anxiety, diagnosis and treatment. And there are a lot of medical professionals who do a wonderful job of discussing these experiences with their clients. However, they may not always provide a space in which to discuss different ways to deal with and handle these issues, specifically as it relates to sex, whether that's solo sex or partnered. But these are the different ways in which to get back into the game, the various options that are available for treatment. We have physical therapy, which is specifically penile therapy, oral medications, which can include the various PDE5 inhibitors or the little blue pills like Cialis, Levitra, etc. There are also various devices that are available to assist, such as vacuum devices, which help specifically with erections. There is the Restorex, which helps with stretching the penis. As I mentioned before, shortened penile length may be an effect that happens after treatment, and so the Restorex can help with stretching. And then also a rather new device called the Baldo, and it allows you to penetrate with your testicles. And there are other options that are available for treatment, such as implants and injections. And it's important to understand that whenever you decide to deal with sexual dysfunction, it's never too late. Another thing that's important to understand is that sex may look very different than what you're used to, and that's perfectly okay. A lot of times we're kind of conditioned to believe that sex has to include penetration of some sort, but you can still have wonderful sexual experiences that are not marked by ejaculation or orgasm. And so this slide talks a bit about how therapy, specifically psychotherapy, can be an option. Sex therapy specifically can provide with guidance and specific suggestions on how to deal with sexual dysfunction, whereas you may work with a general psychotherapist with issues related to depression or anxiety. A sexuality therapist can help with those issues as well, but they have additional training to assist with sexual dysfunction. And it just says here, like I said, the therapist can assist with learning specific strategies to cope with changes, exploring those various treatment options for anxiety and depression and sexual dysfunction. Also, another thing that's important to address is any relationship strain that you may experience as part of your treatment, whether that is whether you're married or have a partner. It's important to understand how that can affect that system. And additionally, you may be thinking about, if you're not partnered, maybe thinking about dating again after treatment. So it's important to know that this is something that's very worthwhile exploring. And working with a therapist, working with a psychotherapist can definitely help you with exploring different ways of doing that, whether that's discussing your confidence or just how to initiate conversations about sex and sexuality after treatment. Again, thank you all so much for inviting me.
Thank you. Thank you. Our therapist here, we learned a new term, solo sex. I like that. That's solo sex. The longer you live, the more you know. Okay, that's very interesting, very interesting. But she's addressing something that's very, very important, the anxiety and stress that comes with the prostate cancer diagnosis and treatment. That is very, very important. I'm going to begin with some questions, but I have one question from an audience member. It's an interesting one, and I'll let any of our panelists weigh in on this one specifically, because this is something we hear at the Empowerment Network. Anything short of seeing a doctor and having any treatment would be some natural remedies. The question is saw palmetto good for an enlarged prostate, and are there any benefits to it? Does it help when lowering the PSA? Any of our panelists can weigh in on that. I'm gonna leave it wide open.
Well, saw palmetto is one of the phytotherapies, and it's got to be the most common of the ones used. Most people use saw palmetto as a natural supplement for management of called benign prostatic hyperplasia or an enlarged prostate, more specifically for men who have troubles urinating. With the idea, if you shrink the prostate with the hole in the middle, you know, when you're 20, that hole in the middle is huge. And as you get to be 60 and 70, the hole is narrow. And so if you can shrink some of the volume, you hope that the hole opens up some. So in the German studies where these nutritional supplements are controlled and regulated, there clearly is evidence that the saw palmetto is beneficial. The US trials aren't quite as good because they're not as well regulated. But in these regulated trials, there's evidence that saw palmetto can lower your PSA by as much as 15%. Now, when you compare that to a pharmaceutical agent like Avodart or finasteride, those agents lower your PSA in the range of 50%. Dr. Andrew here was the lead author on a great study that I quote all the time that says most men who have prostate cancer, at least in that trial, who took finasteride, their PSA only fell by 41%. And the average man who didn't have prostate cancer, if I recall it correctly, their average PSA fell by almost 61%. So it's, again, it's not proof that you don't have prostate cancer based on more or less than a 50%, but I still use it to some extent, yes.
Okay, I made a fatal error. I am the executive director at the Empowerment Network, and I did not give an opportunity to one of our members. Dewey Helms, would you please join us here and give us your presentation from the perspective of a survivor?
Yes.
There
Thank you, Robin.
Okay, put yourself on video. There you are. Okay, now.
Okay,
all right.
There? Okay.
Yeah.
Well, I'm Dewey Helms, and I am a 17-year prostate cancer survivor and member of several of the local support groups that help provide education and information to men on prostate cancer. I want to go back to a couple of things, and just to reemphasize early screening, specifically PSA screening. Dr. Androlin mentioned the study that they did at WashU on PSA. I was part of that trial back in 1995 to 2000 with Dr. William Collon. And I continued to have annual PSA screenings, etc. However, starting in the early 2000s, my PSA started rising, and I had no symptoms, had no indications of what was going on. But all that I did know, though, that the early screenings and the PSA screenings had provided numbers and information that showed that I had a very not advanced, but a very high PSA number that had doubled after several years. So that's how my journey actually started. My urologist and I talked about this different treatment options that would be available. And that's where I met currently Dr. Landis Hall back then, who's currently on the panel today. So I'm not going to get in between on whether a prostatectomy is better or radiation is better. I just say what you need to do is find out what all your treatment options are. Talk to your medical and your healthcare team. Talk about what's best for you based on your age, your lifestyle, your current career pattern, whatever it might be, with your family involvement, and understand that in this journey that you're going to be going through, you have to remember that you have to have diet, exercise, laughter, and spirituality to get through your journey. But to go back and just reiterate the type of treatment I had, Dr. Hall explained the brachytherapy. I had seeds implanted, and following the implantation of the seeds, I did have to take several direct beam radiation treatments. Following that, and over the past years, my PSA has been 0.0 less than 1. So it depends on the type of treatment you take, how you continue to have your annual screenings, emphasizing the fact you should still see your urologist on an annual basis and continue to take your PSA screenings. On that note, I think that's what's also most important is that you should talk to someone who can help you through your journey. You should include your family. You should include some other men that you're involved with or know that can provide, who are close to you, can provide some of the same type of information and has gone through the journey. With that, I became and joined the Empowerment Network, which is the prostate cancer support group in metropolitan St. Louis. We provide education at events, education to men concerning prostate cancer. Also a way for you to continue to get your screenings. There are vouchers available and information that if you need it, you can receive from Empowerment Network in order to continue with that PSA screening that you should be getting annually. With that, if you have any questions concerning survivorship, why I consider the advocate is very important so that you maintain that outlet with other men that you can talk to help them with their journey. And it's a pleasure to be on this panel today with the medical experts.
Absolutely. Thank you, Dewey. We appreciate that. There is a question in the chat, an interesting one, and I'm going to leave this wide open for the panel as well. Are other cancers, for instance, colorectal, etc., screened via PSA? What other screenings will show potential cancer status?
So I can take that one, I think.
Okay, all right.
So what is very helpful with the PSA is it is organ specific. PSA stands for prostate specific antigen, so it is specific to the prostate gland. It is not specific to prostate cancer, meaning that normal tissue in the prostate gland secretes PSA also, which is why there can be less accuracy in the PSA test about if it's elevated, do you actually have prostate cancer, which is why there are additional studies that should be done to understand what that initial snapshot of prostate health is with the PSA. Saying that, because it's organ specific, there are other cancers that we screen for, but we cannot screen using the PSA. If you are screening for colon cancer, which
Yeah.
all people should be doing, some with high risk before the age of 45, but if you are not high risk, average at risk at 45, there are a number of screening aids for colon cancer and rectal cancer. The gold standard is considered a colonoscopy. We also recommend screening for lung cancer, and that can't be done through a PSA. It's if you have a past history of tobacco use of a certain amount, typically over 20 years, or an intensity that's high, more than a pack or two a day, you should be talking to your primary about a low-dose CT scan to screen for lung cancer, because there's a survival advantage with finding that early. And then finally, there are mammograms, and that is with women. And so obviously the PSA is not going to help with that. We use mammography looking for breast cancer. So the prostate cancer is distinctly screened for by the PSA.
All right, thank you very much. I'm going to start with Dr. Reimers. Have some other questions here in front of me. Talk about the various courses of treatment and how long they last. I know that Dr. Hall talked about a daily radiation type thing, and I'm going to get back to her on that. But on your particular presentation, you talked about, I guess, oral versus IV treatments. How long do they last, and what determines that exactly?
Sure, great question. So just to kind of recap again, so the hormone therapy that I mentioned, that androgen deprivation therapy, that's the backbone of all stage 4 prostate cancer treatment, is an injection that can either be given into the tissues, into the belly. That can either be monthly or every 3 months or every 6 months. So every man who's getting treatment for stage 4 prostate cancer is going to be getting those injections. There's a few different slight differences of how those work, but in general, the different formulations have the same goal of getting the testosterone level down. So at a minimum, I would say each man would expect to be getting those hormone injections at least every 6 months, long-term, essentially for the duration of their life, since they do have metastatic disease. So I mentioned briefly chemotherapy. The best data that we have so far is that that's most effective or useful for what we call high volume metastatic disease. The definition of that is either or high risk. So the definition is either 4 or more areas spread to the bone, at least one of those being outside the pelvis and outside the spine, or what we call visceral metastases, meaning cancer that's spread to organs like the liver or the lungs. So that's most commonly the kind of situation where we'd be discussing whether the patient in question would be a candidate for or would be able to benefit from chemotherapy. So like I mentioned, chemotherapy, there's really just one that's used in this very initial setting. It's called docetaxel, or Taxotere is the brand name. It's given by an IV infusion, so you have to spend time in an infusion center. It's given over about an hour, and that's given once every 3 weeks by vein. And then that would repeat 6 times. So the whole course of treatment for that is 18 weeks, but you really just get 6 different treatments. And then after that, patients kind of get a break, and it gets a little complicated there in terms of other potential treatments and what the PSA is doing. But in general, after that chemotherapy is done, patients just continue to receiving the hormone therapy by itself. And in contrast, if we're doing the type of treatment where the hormone therapy shots continue and we add the pills are given daily. And I didn't go into this in a lot of detail because there's a lot of complexity, but suffice it to say, most of these regimens have 4 pills that have to be taken every day all together at the same time. One of them specifically has to be taken on an empty stomach with a medication called prednisone with it, but the others just are by themselves. And that's a daily pill until either the patient doesn't tolerate it or it stops working, meaning the scans show that the cancer is growing again or the PSA is rising again. And it really depends on how long that might last. Sometimes that can be up to a year or 2, depending on how long the cancer is responding to it.
Okay, here's the ultimate question. Let's talk about insurance coverage. I'm sure the These treatments are expensive, I'm certain. Talk about that. And do you have that conversation with your patients about the cost of treatment when you're discussing with it? And that's a question for everybody, but I'll let Dr. Reimers continue.
Sure. Robin, I'm really glad you asked that because it's actually really important. And I will say, unfortunately, I do have to, and I do talk about my patients with that. So the hormone injections, for patients, generally for patients that have insurance, the hormone injections are covered, and there should not be substantial copays for that. Chemotherapy, the chemotherapy has been around for many years now, and it's generic, and so it's also covered by insurance, and there's really no issues from an extra cost perspective there. You're correct that the biggest financial question really comes with the oral hormone pills. And so obviously, those are indicated for, different ones are indicated for certain phases of stage 4 prostate cancer, but they're all approved and they're all covered by insurance. The problem is that they're so expensive at baseline that the copays can be substantial. And unfortunately, we really can't tell patients what the out-of-pocket cost might be until we run it through the insurance and we know what that copay is going to be. But there are a number of patient assistance programs through the different drug companies. We have some other assistance programs through Siteman Cancer Center. But I'm sorry to say that sometimes it does factor into which treatments we sort of decide to use as a first option or even later, because sometimes the copays can be prohibitively expensive, to the order of several $100s a month to sometimes several $1,000s a month, where we just can't close that gap. And so unfortunately, that's still a big problem in our healthcare system.
Mm. Yes, it is. We're picking up some questions in the chat. I'm gonna go with the ones that came in first, as always. Can you comment on whether prostate cancer survivors should get vaccinated for COVID-19? We've been doing a lot of work inside of the Empowerment Network about COVID-19, the virus and the vaccine. And this is a very good question for our survivors, exactly what it is and what they can do, and also to overcome the, I guess, the fears that we have as it relates to African American people about our past histories in medicine in the United States. So I'll open that up to anybody on the panel about cancer survivors and the COVID vaccine, whomever would like to start.
We've put together a document to help our cancer survivors understand if they should receive a COVID vaccine. With regard to radiation, we have absolutely no restriction whether you are receiving radiation or you're a survivor and have radiation with respect to having the vaccination. I think Dr. Reimers could speak to whether you're actively receiving chemotherapy or not, and whether she would want you to have a vaccination. It's important to talk to your medical oncologist, but even with the hormone therapy, we do not have a restriction on getting the vaccination. I would say that it is important to have a frank discussion about getting a vaccine and the importance of not just saying no off the bat that you won't do it, but understanding that the reason that there is hesitancy to become vaccinated is a real and authentic concern, that it is marked in historical abuse, medical abuse. And if there's one thing any person wants to have, it's control over their body. And so I think it is wise for us to start off saying it is appropriate to feel the way you feel. I chose to be vaccinated, to get the first and second injection, which came on January 8th, because I wasn't clear on two things. You never know what my experience might be if I developed COVID-19, because we don't know. And though some people are asymptomatic, close to 40%, we know that there are some people who won't survive 4 weeks after the diagnosis. And because I did not know that, but yet I did read the clinical trial data related to both vaccinations and realized that it was safe, and that it was effective at 95%, I chose to not want to expose my patients or my older family members, my mother and father, to me potentially being symptomatic and spreading that virus to them unknowingly. So I made a personal decision, and we all have to, but I think what we must do is say that the hesitancy and concern about taking this vaccination is baked in a reality that's authentic.
Any other thoughts out there?
So I can share a little bit kind of from the medical oncology side. So I completely echo what Dr. Hall said about, acknowledging the importance of hesitancy around vaccines. And the way I've been kind of opening that discussion with my patients in my clinics recently is just to say, have you thought about the vaccine? Do you have questions about it? And actually, a lot of my patients are approaching me, to ask, do we have it available? A number of patients have been eager to get it. But I think the conversation around that is really important as a starting point. And again, echoing what Dr. Hall said, so certainly for prostate cancer survivors who have no active cancer, really that doesn't really factor into the equation as to the safety of taking the vaccine. And really, I think that sort of emphasizes the importance of considering taking it, especially for patients that might have high blood pressure, diabetes, heart disease, other factors we know they're predisposed to having a more severe course with COVID-19. Specifically from a cancer treatment perspective, we've come up with some guidelines through the Cancer Center generally about how we're thinking about which patients should be offered the vaccine and where we might need to do some more thoughtful discussion, just because the clinical trials don't widely involve cancer patients on cancer therapies yet, and so that's still an open area of investigation. But in general, we do not have any concerns about giving patients either on the hormone injections or the oral hormone pills the COVID vaccine, because that's not really impacting the immune system at all. And that's another misconception I come across sometimes, is that none of the hormone type treatments have any direct impact on the immune system. So there's really no restrictions there whatsoever. For immunotherapy, which I didn't cover at all today because it's not directly approved for prostate cancer, but for things like immunotherapy in patients who might be on clinical trials, it's really important just to discuss with your medical oncologist whether the clinical trial protocol allows it or whether there need to be specific modifications. I think the most clear guidance that we've come up with so far is for patients on chemotherapy, where we know that that's directly suppressing the immune system and potentially impacting how effective the vaccine might be. And so what we're really trying to do there is, if we can't wait until the chemotherapy is done, or if we really need to finish that course, then we try to give the 2 doses of the vaccine around the time when chemotherapy is being given. So ideally kind of after 2 weeks after the dose, and sort of shuffling around it as close as we can, if that makes sense. So as Dr. Hall alluded to, there's really 2 primary vaccines that are available right now. The Pfizer vaccine, which is given in 2 injections 3 weeks apart, and the Moderna vaccine, which is 2 injections 4 weeks apart. And so depending on which one might be given, the staggering of the vaccines and your chemotherapy might be different. But I would just emphasize it's just really important to discuss with your medical provider any concerns you might have, or any potential adjustments or restrictions with your treatment, just to make sure we keep cancer treatment going and keep everybody safe as you're taking that and as you're getting the vaccines.
Very interesting, very interesting. We have a question. I'm going to pose this one to Dr. Bullock and Dr. Andreoli. The gentleman says, what can you do to lower your PSA? I have a Gleason score of 6, and I'm on active surveillance with a PSA of 4.8. Dr. Bullock?
Drew, you want to take that?
No, go ahead, Arnold. Go ahead.
What can you do to lower your PSA? Well, this is what I tell people when they ask me, how can I lower my PSA? The PSA in and of itself doesn't hurt you. The PSA is there to help uncap a sperm cell to aid in fertility. So the PSA is a natural agent. In and of itself, it doesn't hurt us. It's a marker. And so this is where I tell them, why would you want to lower your marker? Why would you want to take down the sign? If you had a bomb in your basement and someone took the sign off your front door and said, there's a bomb in the basement, they said, that's a terrible sign. Let me go take that sign down. Did they help you? They didn't help you. The bomb is still there. So the PSA is a marker for whether or not you have prostate cancer or not. So artificially lowering it for instance, with finasteride, may not be beneficial. So the PSA doesn't mean that you have prostate cancer, it just tells you your level of risk. And as Dr. Intro mentioned earlier, we now have a whole bunch of tools that we could say that might be a little bit better than PSA to give us our real risk of whether or not we have prostate cancer or not, or to be used in conjunction with the PSA.
Okay.
Yeah, I would just add, you know, even if the PSA goes down, that doesn't mean your cancer's gone away, right? So you can lower a guy's PSA almost to zero and he still has living prostate cancer. So we can't rely completely on PSA changes to tell us whether things are going good or going bad, kind of thing.
All right. Ms. Blaylock Johnson, I'm going to pose this one to you. It's in the chat. Explain solo sex.
So solo sex is just another word or another term for masturbation. Anytime that you're having any type of sexual experience with yourself. So that's what solo sex is. It's just another term that I like to use. The term masturbation just has a negative connotation, whereas solo sex just sounds a little more fun. So.
I like it. I'm gonna steal it.
Yes.
I am too. I was just thinking, boy, I learned something today. This is
Yeah.
fantastic.
Yeah, that's a very good term. It's a lot easier on the ears to hear it that way, isn't it? So,
Masturbation has all these consonants. It's just kind of hard on your ears, but solo sex.
It's very easy.
You know, yeah.
It's very universal. It just feels like you could just go out into the universe with that. Okay. Okay. Dewey, I'm going to put this one to you. This is from our own Melvi Shahid. How important is a support group to your prostate cancer journey? And
What that provides, support group is a way to connect with other men who have been in your shoes. It's a way of knowing that men have had a similar journey and can help answer questions and issues that you may have to help you to cope. In the support group, you're going to encounter men that have had all different types of treatments. So it gives you an opportunity to talk to them, find out what their symptoms were, what their outcomes were, the type of treatment they had, and your decision making. It's also a way to just continue with that contact with people, to continue with that humor and that spirituality, and knowing there's always someone that you can call on and you can talk to. So it provides an outlet for you to help deal and cope with stress. Got it? Yeah.
okay, did we lose you? Okay, you're done. I have a question for.
Robin, can I expand on that a little bit?
Yes, please.
I should make sure we give props to the Empowerment Network. And I'm not sure everyone on the line realizes how blessed we are as providers and as community people for having the Empowerment Network in our St. Louis community. It is clearly one of the top, in the country in terms of the size and the expanse of what they do for our patients. Whenever I have a patient, I usually, between Leona, my nurse, and myself, suggest that they might want to go to one of the Empowerment Network meetings, because they can actually meet my former patients. They can talk to men who've had radiation, different types of prostate surgery. But not only that, you have a lot of men who are single or widowed, and they have no support. And I can't tell you how many times I show up at my hospital and at Christian, when I get ready to walk into the waiting room, the holding area, to see my patients pre-op, whenever I see 7 brothers of mixed race sitting there, I know exactly what they're there for at 6 o'clock in the morning. They're there to provide support to a gentleman, whether or not he's there alone or with his family, and the hospital recognizes him so much that this is the only group that I know that they let come in that number to see the men and have a prayer pre-op. And so credit needs to be given to Robin, Melvin Shahid, Dewey, the entire volunteer staff, the Empowerment Network Auxiliary, it's just an amazing group. And if as a provider, you're not sending anyone to it, you should hook up with Robin and get some more details.
Thank you, Dr. Bullock. We appreciate that. And we are here for the prostate cancer survivors. We are a resource in all ways across the board, pre-surgery, post-surgery, all the way through your relationships, as you've heard from Ms. Blaylock Johnson. And we do appreciate his shout out. We take referrals from physicians in the area. We'll take self-referrals. If you call our office with questions or concerns, then we certainly will have a response for you and a potential referral for you to a physician about your condition. So we're 12 years old, and we just, it comes from our heart. Started with the passion of Melvi Shahid, but I won't get into all of that at the moment. A couple of other questions here. One of them has to do, and I'm going to ask a question specifically to the doctors. Dr. Bullock mentioned what happens prior to surgery. Yes, we meet the gentleman and his family at the church. I mean, at the church, it's a church thing, at the hospital for prayer, and we follow up after. Talk about what happens after surgery. When the gentleman leaves the hospital and he's at home, what happens at home? Is he on a catheter? What does that mean about his mobility? And I'll take that answer from any of our physicians.
Well, it depends on what treatment. Dr. Hall will talk about radiation and the different types. But for every man who has his prostate removed, so keep in mind, the prostate sits right below the urinary bladder. And so you have the urinary bladder that stores your urine. The urine goes right through the middle of the prostate. Then it goes through your penile urethra, right? So when the prostate comes out, you have your bladder here, you have your urethra here, and there's a gap. And what we do is sew the bladder back down to the urethra. And we leave a catheter in as that connection heals. So it stays in from 7 to 14 days, depending on what type of surgery you had. The catheter hooks up to a leg bag. You could have a 250 cc leg bag that holds 4 hours worth of urine, or you could watch the Super Bowl and put on a 3,000 cc leg bag and keep that thing on all day after a six pack. And so people's pain is usually from putting it in. It's put in the operating room. It slats out fairly easily. It does cause a little bit of bladder spasms where you get like a little cramp, but there's medicine to control that. So in and of itself, the catheter is sometimes overblown, but again, talk to a former patient like Mr. Helms, who could give you more details on it if you really want to know the specifics, because I must admit, I'm only giving secondhand information.
Well, when he speaks of being on the catheter, one of the things we give to the survivors when we go to the hospital is an after-surgery kit, which contains hygiene and personal items you need when you're at home, especially for men who have no caregiver with them at home. And they're going to need some things because they cannot get in their car and drive around, basically. We give them a robe that they can wear very comfortably with the catheter, and toilet paper, face soap, just things that you need in order to get through those 7 to 10 days. And that's just a gift from us for the beginning of that journey. There's a question here that says, this gentleman's PSA dropped to 0.0124. What can be done to reestablish your testosterone and reduce night sweats?
Yeah, I'll take that one. Yeah, if he had prostate surgery and his PSA went down like that, and the report we got from the pathologist said there was no spread of his cancer, for me, I feel it's okay to give him testosterone supplementation, provided we carefully monitor the amount of testosterone that gets into his bloodstream. We don't want to overdo it. And there's no reason that he should have to spend the rest of his life with a low testosterone level. So I think it's safe, provided he gets his testosterone measured every 3 months or so to make sure we're not overshooting.
Interesting.
Jerry, I have a follow-up for you on that. Would you do that in a gentleman who was high risk disease that you operated on?
That's a great point, Lannis. No, that's why I say you have to look at the pathology report. And this was all about if he had a radical prostatectomy. And we were confident that we cured him. I think it's okay for that subset of men. But you're right, there are other findings. If it was a very aggressive cancer, if there was a worrisome margin or some other adverse finding under the microscope when the pathologist looked at things, then that's a different matter completely.
Interesting. Here's a very interesting question from a married man. He says, I am under active surveillance and would like to know if I'm having sex with my spouse, can I pass cancer cells to my spouse?
I think we can all say this in unison. No. No, you cannot. And please feel free to be sexually active or engage in solo sex, whatever you would like to do.
All right, that's simple answer. The answer to that is absolutely no. That's great. These have been so enlightening, even to me. I've been with the Empowerment Network for 6 years and have interacted with all of these physicians on this panel. I learned something new I've been taking notes the whole time. Let's go back to DeAndrea. DeAndrea, of course, the anxiety and the stress of the diagnosis, as bad as it is, and whatever happens after in terms of surgery and recovery, we now have COVID, which has quarantined so many, well, everyone basically at some point. How do our cancer survivors cope with the quarantine with a spouse or a significant other on top of having to deal with the disease?
I tell you, one thing that I've noticed is an uptick in couples seeking therapy, specifically with being in quarantine. A lot of times we have the ability to separate, and quarantine has brought us together. And so I think it may be really helpful to reach out to a relationship therapist who may be able to help you deal with some of the stresses and issues that may be coming up during quarantine, in addition to dealing with the diagnosis and treatment and the issues that may arise from that. So I would definitely suggest reaching out to a therapist to help you for your specific issues.
That's interesting too. Now, for the people looking out there, you're going to see a post-test pop up here shortly, just to see what you've picked up in the past half an hour and a half or so. And there it is. And we will give you some feedback on that as the minutes wind down. We've got approximately 12 minutes before we're done. So I'm going to encourage everyone out there that has a question, no matter what, just pop it into the chat or Q&A, and certainly we will bring it up. As we move to a close, are there any new, and that's the one thing that I have seen also, are the cutting edge things that have happened in prostate cancer surgery and diagnosis and treatment. Is there anything else out there that we haven't, that's just kind of formulating on the horizon that can be of a very important impact to our members? I think about the genetics. Are there any other advances in genetics? And how far reaching is this? Not just cancer diagnosis of the prostate gland, but we know about breast cancer. What about colon cancer or any other cancers? What's out there on the horizon?
I think Jerry touched on it, and that is using genomics to predict the behavior of a cancer. I mean, we've always looked at prognostic factors to determine how we should treat, but we can use genomics. What has driven this prostate cancer to develop, and what is the likelihood of developing metastasis? What is the likelihood of dying of this disease? Having the genes that drive prostate cancer growth evaluated, and therefore adding that level of information in and a bigger algorithm to understand how aggressive to deliver care, if we need to deliver care at all. And if we do give care, do we need to give additional care? Because despite what we are giving, it may not be enough. So it is informing our clinical studies. And it's also, I think, a way of taking people out of groups where we might have treated them one way and not treat them at all. And on the other hand, people who we were thinking we were going to watch carefully with active surveillance, maybe not do that because the genomics are saying, no, this is a very serious prostate cancer.
Interesting. Let's talk about insurance too, as it relates to genetic studies and counseling. What kind of coverage are the insurance companies doing for this? It's relatively new. Are they covering every type of genetic test, or is this something that we need to do some legislation about? That's for any of you.
I can briefly,
Go ahead. Go ahead. No, go ahead.
I can briefly speak to that. So I will just kind of add to what Dr. Hall was saying. Certainly genomic testing in the metastatic prostate cancer space has definitely become much more common, so much so that we're really getting genetic analysis of the cancer cells, of those spread cancer cells for pretty much all of our stage 4 prostate cancer patients. And what I routinely do at this point is we send a type of test that looks at both the genetic changes in the cancer cells themselves, those are called somatic mutations, and any genetic changes that may be in the patient's blood, so in their normal healthy cells, and those are called germline mutations. And the germline mutations are the ones that can be passed down from families. And that's where I always take a very detailed family history, where we need to think about any family members that might have had prostate cancer, family members that might have had breast cancer. Some of the audience members may have heard of things like the BRCA or BRCA mutations, and there are known hereditary cancer syndromes that can put families at risk for prostate, breast, and ovarian cancer, especially in our younger patients and, men or then women in their families where they're having those types of cancers in their 40s, 50s, or there's multiple family members. That sort of sends a flag for all of us to say we're worried about a potential genetic syndrome. And so often what I will do is, as a first step, I'll go ahead and get that test that looks at both the cancer cells themselves and the blood test. And then I will also refer patients to one of our genetic counselors who can look at some of that initial information that we get and also make recommendations as to whether a broader panel of germline testing needs to be done, so to look for inherited mutations, and or whether other family members maybe need to be tested depending on their risk, right? There's always concerns about children, grandchildren, those risks that are, those genetic changes that are potentially passed down through families. From a copay perspective, so the specific test I was referring to that we send, we often use a company called Tempus that's typically covered by insurance, and sometimes there can be a copay of up to about $100 or so, but if that is there, often the company can waive that. And then when the genetic counselors specifically do more in-depth testing, they will definitely discuss what kind of copays may come up from that perspective.
That's very interesting. Good for our listeners to hear that. Absolutely. One other question in the chat over here. My son was screened and found cancer due to PSA test results. He was told they would check him every 3 to 4 months. Okay. What food should he do? What limitations should, if any, I, as his mother, long distance, can do and say? It hurts me to discuss it. I worry about his emotion. Okay, so here's a caregiver, long distance from her son who's been diagnosed. What she's looking at recommendations, and also what kind of support she can give. And I'm going to throw the recommendations to all the doctors, and I'm going to do with the support to DeAndrea.
I think Jerry mentioned from the beginning, don't get really alarmed. He clearly has a prostate cancer where they're following with active surveillance, so it is probably low risk. The key is to make sure that he is going to be followed every 4 to 6 months, that they will consider MRI imaging and follow up in a confirmation biopsy to make sure there's no progression. But Jerry, I know we'll talk about that. We did a study for men who were in active surveillance looking at the role of 5 to 9 fruits and vegetables in a low-fat diet to see if that in any way reduced the number of positive biopsies with men who are on active surveillance, to see if in the future you saw less positive biopsies, a change in the PSA. What we found was, unfortunately, it was a negative study. We didn't find that 5 to 9 fruits and vegetables in a low-fat diet reduced those parameters, but it did do a great thing for cholesterol, high blood pressure, and overall cardiac health. So I would say, you know, a healthy diet is important, even if we didn't see the results we wanted to see in that study. But Jerry, I would ask, is there anything out on the horizon new for these men with active surveillance outside of the PSAs and confirmation biopsies and MRIs? I know a lot of men struggle with having to have another biopsy done.
Yeah, Lannis, that's true. You know, active surveillance requires careful follow-up. You got to have your PSAs. You got to have MRIs. We're striving to avoid the biopsies because that's the most toxic, if you would, part of the whole thing. And as MRI gets better, as this micro ultrasound, which is really brand new in the United States, we've been using it now for about 1.5 years. It is really reassuring if we do the ultrasound without doing a biopsy. If there's no abnormality on either the MRI or this micro ultrasound, it's looking increasingly like we can avoid, you know, the biopsy with all of its side effects and costs. The only other thing I'd add to the mom who asked that question that I think actually is beneficial for active surveillance is exercise. There's a couple of studies out there that show, you know, exercise in addition to a good diet and a stress-free life, if you can get there in these COVID times. Those are the things that actually seem to be very beneficial.
Yeah.
That's interesting. Okay, we are approaching our 1:30 deadline, and we have had some excellent conversation here about prostate cancer. And I certainly do thank all of our participants, our physicians and our therapists and our survivor as well, for the viewpoints and the perspectives that you have brought to this particular discussion today. I will say for follow-up, if you're looking at chat, other events coming from PCAD, because PCAD has done town hall on breast cancer, and they will continue to do them. If you will click on the link that you see in chat, that will give you more information. If you are looking for support for your prostate cancer survivor or someone who's been recently diagnosed, please contact the Empowerment Network. We have many resources. We have a weekly prayer call. We do a monthly support group. We're all virtual at this point. This is not face-to-face. We can still distribute the after surgery kit, even if we know that you've had surgery, and we will take referrals from you or from a physician. And our number is 314-385-0998, 314-385-0998. There's another quick question here, Dr. Andrioli, you brought up about exercise, and he's asking about lifting weights. What about lifting weights?
That's a good form of exercise. You know, that's just fine. Everything in moderation, don't overdo it, of course, but no, that would be a good thing.
Okay, absolutely, absolutely. Any final comments from anyone? We do thank you heartily. There was an earlier question about when is the next one. So maybe we'll do one quarterly, or at least in the second half of the year. We'll come back in July and see what has occurred, and have we gotten out of the umbrella of COVID enough to get back face-to-face. Maybe we can go face-to-face at some point in the future. We had initially close to 60 registrants for this particular presentation, and I encourage any of the women on the line to talk to your sons and husbands, uncles, brothers, dads, grandfathers, any man that in your purview who you think would benefit from this information, to reach out to any of us, as well as to call the office, 314-385-0998. Absolutely.
You know, to that end, Robin, I would suggest that when people get the message of the next town hall, that you try to think of a dozen men, you know, over the age of 35 or 40, you know, and just send them an email. Everything's electronic now. So look at your phone, just, you know, because you could help this meeting with 300 people on it, you know?
Absolutely.
And
Absolutely.
so the more the merrier, because breast cancer gets known about because women are so open to, well, I can't say that, but they tend to be more willing to tell family members and other people and encourage other women to be screened. And we find that that's a problem amongst the men. Oftentimes men won't tell their own first-degree relatives or cousins that they have prostate cancer because of the, you know, potential general lay people's impressions of what that means. And so sending out the information that we are having these town halls, I think if you could let someone know and have their cancer picked up at an earlier stage, man, what a, you know, you only need to do a few of those things in life to say that you were successful, you know?
Very true. Early detection is very important. Spread the word for sure, at all levels. Anything.
Robin, one more thing.
Yes.
Advise anyone that needs a PSA screening, also call your office so that we can provide a voucher and information on how you can get your PSA screens, since we're not doing local events.
Yes. Yes, that's very true. Very true. I'm looking to see if we have any of the pre and post test results yet. Kelly, do we have anything, or is that something we may have to send out by email? Okay, there we go. All right, here we go. What did you learn today? What did you, okay, this is our post-test results. True or false? Okay, am I reading this right? What did you, please retake the anonymous test from the beginning of the webinar to find out. True or false? All men are at risk for prostate cancer. 30% say true, 70% say false. So the answer would be true. I would think all men, and I'm not the physician, so you all have to pop in here.
The key word in that question is equal. All men are at equal risk for prostate cancer. We know that's not true.
Not true. Not
so based on, you know, race, and age,
Family history.
family history, geographic location around the world, that African American men are at much higher risk of prostate cancer. In fact, twofold higher than white American men. Asian populations, especially if they're still in Asia, are significantly lower risk than white Americans.
Okay, number 2, which one of the following is not a common side effect of hormone therapy used to treat prostate cancer? 80% of the men say chest pain, or I should say the respondents said chest pain.
And that is the correct answer. So I'm glad you all learned something about hormone therapy. That's great.
Okay. Number 3, true or false? Orgasms and ejaculation are necessary components of fulfilling intimate experiences. 85% say false. Another correct answer.
Yes, that is false. Orgasms and ejaculation are not necessary components for fulfilling intimate and sexual experiences.
All righty then. Tools to assess a man's risk for prostate cancer include early in life PSA, family history, genomic risk score, all of the above, only early PSA and family history. All of the above, 85%. We good? Is that right? That sounds right. Okay. Is that right, Jerry? Okay. True or false? PSA testing reduces the chance of men developing metastatic prostate cancer. And 45 say true, 55 say false. Reduces the chance of developing metastatic prostate cancer. What's good there? 55, false?
Who wrote that question?
That's a hard question.
Who wrote that question? Because it's not PSA testing as much as you acting on it.
Right.
You can do a PSA test all you want, but you've got to act on what is that snapshot of the health of the prostate. If you watch your PSA go up to 20, 30, 40, 50, don't seek out medical attention, or refuse it, then you can march your way right into metastatic prostate
I have
cancer.
an exact same scenario as that. A gentleman that I saw probably 2 years ago with his PSAs in the teens. And I checked to see that we even did follow up, made calls. And we saw him just recently, and the PSA's like 180 now. And more than like overly eager to get in there. It just like, you're exactly right. You know, and when I see these, I try to put it in plain language sometimes. Just like Dr. Andrew used to do a lot of kidney cancer. People say, I'd rather die than get my kidney out. You got some big hunk of kidney cancer, it's almost for sure you will die. And you know, and so sometimes you put it in plain language, and still it's hard to get people to see how blessed they are to be picked up at an early stage or to be screened at an early stage.
I would say that the key take home there is that PSA testing improves the chance of early detection, right? That is the key. And I think the question of whether metastatic disease will come at some point, whether you'll be stuck with me for a long time or not, is more so dependent, unfortunately, on things like biology, right? But the earlier it can be found and addressed by Dr. Hall and Dr. Andrew and Dr. Bullock and cured, that's the important part, you know?
But since PSA's been out, proper use of PSA and follow-up of PSA has reduced the rate of metastatic disease.
Absolutely.
Correct.
No, I mean, I understand the intent of the question. I guess we're struggling with is what Arnold and I see a lot and everybody else, and that is people who won't act on the information in a timely fashion, and that is heartbreaking.
Right.
Yes. And I see that too, right? Where I kind of see the backstory, and then people come to me and then frankly, in a way, it's too late, right? That we lost the opportunity to get cured by Dr. Andrew Bullock and Hall. And I'm more than happy to take care of every one of my patients, but it's heartbreaking when we could have prevented that, for sure.
Interesting. Last question. Radiation therapy is a treatment strategy for which group? Low risk, intermediate risk, high risk, after surgery, if worrisome findings are reported, all of the above.
I feel like I failed, Robin. I have failed. Everybody is in the 80% range, and we're sitting here at 65%. Help me. I have failed. You know, curative radiation therapy is a treatment for all risk groups and can be helpful after surgery. There's indications for it after surgery if we find surprising factors on the pathology report. So it is all of the above. It can be used in a palliative setting to make pain worse and extend survival. So it is all the above. I'd like to just say that I think this is an incredible panel. People don't realize that Dr. Andriole and Dr. Bullock are world renowned, not just state renowned, but they are amazing in their field. And Dr. Reiners is just an amazing medical oncologist, and it is an honor to be on the panel with these great doctors. Thank you for having me, Robin.
So, Robin, I got to make one comment before. I know we're getting late, but this is the thing. This is what I tell my patients. It sounds stupid. I come out with all these crazy analogies. I say, if you wrecked your $50,000 Buick, how many shops do you take it to get an estimate before you choose who's going to fix it, the body work? Usually 2, 3, 4. How many surgeons do people go to when they have to get half their liver taken out? How many surgeons does the average person see when they need a lung removed? 1. So why not take your car to this shop, that shop? Why not go see a surgeon and get a second opinion? Why not get a second opinion on radiation oncology? Why wouldn't you feel like you know as much about cancer and your options, not because you listened to your barber, but because you saw specialists like we have on the panel, so you know that you're making an informed consent. Always blows my mind. Yeah, I say, dude, who'd you pick to put this? I do a lot of penile implant. Where'd you go to get this penile implant put in? Did you ask him whether or not he does more than 1 or 2 a year? You know, this amazes me. And so you got to get other opinions. And I refer people to Lance Hall all the time. You know, I mean, you need another opinion sometimes.
Absolutely.
You know?
And to that end, I'd like to ask the physicians, and you're all WashU School of Medicine, but you're in different facilities. How's the best way to reach you? Are you only through referral, or could our listeners actually call your office and get an appointment? And is there a central number for appointments okay, I see Dr. Andreoli shaking his head. What is that number?
For urology, it's 362-8200. And that'll get us to our call center, and they'll route the call to the appropriate facility or doctor.
Okay, all right, we heard that. 314-362-8200 for the physicians and 314-385-0998 for the Empowerment Network. And you can go on Facebook and look for PCAD and pick up on anything that's happening with our particular group. Once again, thank you so very much for this time that you've given us this afternoon, and we look forward to doing this again later in the year. We're going to measure, I'm sure I'm getting a lot of attaboys in the chats and even on my phone that we did a good job today. I think we have helped the community dramatically. Yeah. So thank you all, and have a good rest of the day, and stay safe, and see your doctor routinely.
Thank you, Robin.
Thank you all so much. It's a
Thanks for
pleasure.
putting us on.
Take care.
All right.
Bye-bye.
Bye-bye.